In residency, I got most of my intramedullary nail training and experience by Dr. McGlamory and Dr. Camasta, and now this is a procedure that I've used throughout my practice and has been very successful with my patients. Dr. Carter and Aaron Bradley, who's here, just worked on publishing or putting together the next ankle fusion chapter for the McGlamory textbook, which will be coming out. And these are some of the highlights of the intramedullary nail considerations that we discuss in the textbook chapter. I have no disclosures, and today I'll do my best to speak in generalities as far as which nails are on the market and available to you. Intramedullary nailing has several advantages. First, it's minimally invasive, and you see in this picture, we've prepared an ankle fusion. We resected the joint here, and I think we did a good job. This was in preparation for an anterior ankle plate and fixation across the malleoli. You can see the extensive periosteal stripping that's required when you are using this internal fixation. So you don't need as much of that when you're using your intramedullary nail. You can have a smaller surgical footprint. The intramedullary nail also allows you to achieve maximum compression across the tibio-talar joint, and we'll show some examples of how that's performed and how that works. The technology has advanced to the point that we can even achieve dynamic compression across this joint, and that allows for early weight bearing. Overall, these cases do well with the tibio-talar calcaneal fusion. 74 to 93% union rate is reported in the literature, and the results are excellent to good at about 84%. Disadvantages, sure, there's going to be disadvantages to everything, right? This certainly is going to take a little longer, takes more time to do this than just throw your two percutaneous screws crossing the ankle. There's going to be more expense as there's more fixation as well. If you have to remove it, you have to make more incisions, you have to take more time to remove it also. Stress fracture. Periprosthetic stress fractures are one of the considerations we'll get into today with nail selection. But certainly this can be a challenge and a headache to manage and treat if and when these occur. Infection, this can be a conduit of infection. Instead of just having infection localized to your hardware in the ankle joint, now we're extending it up into the intramedullary space up the leg. Okay, so here's a picture of a patient that had two cannulated screws placed across the ankle joint. You can see that this went on to non-union. This wasn't sufficient enough to do the job. Internal fixation can be more robust in our diabetic patients especially. This is a nice example where you can see we've stacked our fixation, spanning it from not just medial to lateral, but also front to back, anterior to posterior. And that's a nice construct, more robust certainly than our 2 points of fixation across the joint here. You'll see though that the subtalar joint has not been affected, right? So in the intramedullary nail cases, we're talking about sacrificing the subtalar joint and the ankle joint. We had a case presentation yesterday of a tibial deformity in which we had a discussion about not performing an intramedullary nail. It's something that we don't want to miss. You can see here this patient had an old tib-fib fracture that healed. The alignment's not horrible, but in this case I elected to go with screw fixation across his tibio-talar calcaneal fusion sites. So today, this is the roadmap of the talk. I want to get into some discussion on the nail design and the options that are available to us. Briefly, we'll go over guide wire insertion, subtalar joint prepping, indications with trauma, and antibiotic nail preparation. So the first question is, should you use a short nail? Should you use a long nail? Should you use a straight nail? Or should you use a curved nail? These are the options that you have available when you go to select your nail for your patient. The important thing on going short or long is you don't want the nail to end in the isthmus of the tibia. That's where it's the most narrow in the canal. And you want the nail to end in a central location intramedullary. As you go to longer nails, sometimes you have to use perfect circles and get that screw into the nail without using the jig, and that can take a little bit extra time if you're not comfortable doing that. The overall goal here is we want to be central in that intramedullary canal though, so we're not going to have a stress fracture reaction. And that gets into the discussion of should we use a straight nail or a curved nail. And I like to order this Saltzman view long leg image prior to surgery so we can really assess that specific patient's alignment. So if you look at this, you see the axis of the tibia, and you see the axis of the calcaneus. And they don't line up very, they don't parallel each other, they don't line up in the same orientation. So I know if I'm going to use a straight nail, for example, on that patient, that we have some work to do, maybe some wedge resection to get that more linear. This is an image from an article Higher published in 2013. The cadaver study, they drew a wire straight down the tibia axis through the ankle and down the bottom of the foot, and you can see where it comes out in the calcaneus here. And this is a real issue that we have in some of these patients. It comes out more medial, and that means that we're not getting the full purchase through the whole body of the calcaneus, and your purchase is going to be less in the construct. Even if you get a screw across that, it's not going to be as strong because of the lack of the purchase in the calcaneus, especially in the osteoporotic bone. For example, the Charcot patients that we use our nails on. So there's been development of curved nails, and the whole point of this is that we want to stay within the calcaneus, within the tibia. We want to purchase the calcaneus, we want to stay central in the tibial canal. It's also said to be beneficial as far as avoiding the planar neurovascular structures as they're more medialized also. So this is an example, unfortunately, that I experienced of a stress fracture proximal. And if we're not intramedullary, especially in the proximal aspect, or if you end the nail in the isthmus, this is something that can happen. You see that the stress fracture occurred here. There's robust bone callus formation. But this is, in an obese patient especially, still not an optimal scenario. It's not stable. And unfortunately, we had to get ortho involved, and this was converted into a longer intramedullary nail through the tibia, went on to heal and do well. But this can be a challenge, especially for your patient that you've kept non-weight bearing for 3 months after your Charcot reconstruction, that now you have to tee up and keep non-weight bearing even longer. Okay. So again, short nail versus long nail, what's the literature say? Marley in 2014 discussed this and said that there's the best proximal centering using a long nail, whether it was straight or whether it was curved. And then they went on to look at the cortical hypertrophy in the tibia proximally there, and they found less reaction in the curved intramedullary nails. Wilkich in 2015 reported on 117 short intramedullary nails and found the overall proximal stress fracture reaction in 3.4%. The treatment for this was to exchange that short straight nail with a long curved nail, and they recommended that that's what we do primarily. So these nails are no longer on the market actually, but I just wanted to show that there are nails designed not just with a valgus rotation to them, but also a posterior bend to them. And I believe a couple of the companies are still working on this and trying to figure out the best angulation orientation, geometrics to perform a design of a nail that stays intramedullary in the tibia and also comes out the calcaneus to have a good purchase. So I just put this in here. This is an example of a case I've done. In doing a talectomy, you've taken out some of the rotation and you can neutralize that calcaneus under the tibia well. And in this example, I tend to go with a short straight nail. Okay, next, if we look at the biocomposition of the nail, it's important to think about what is it made out of, because we want to avoid over stress shielding this. With Wolff's Law, we need to have the bone stressed so it can deposit bone and heal. And if we look at the Young's modulus elasticity of stainless steel versus titanium, and this is bone down here, the closer the Young's modulus is to the cortical bone, the more stress that's going through the joints, and it's not just taken up by the fixation as shown here. So most of these nails are going to be made out of titanium because that has a lower Young's modulus of elasticity and can share that across the ankle and the subtalar joint. There's also a carbon fiber nail option, and I learned about this a few years back. Dr. McGlamory lectured on this, and something I've tried about all these nails. But you can see that this is difficult to even see radiographically, and you see a small little wire showing you where the nail is and where your screw sites are. But it's pretty cool, and this has even a lower Young's modulus elasticity than titanium, and has benefit in that it allows you to see your fusion site and your consolidation across the joint. There's various screw options. Every company has their own twist on this, but the screw options come headless, low profile, or even with blade technology inserted to lock this nail. Various different options as far as the number, location, and the orientation of your screws also. You can just see here a couple shots from the technique guides and manuals of some of these products. O'Neill in 2007 published a study that showed that an ancillary screw crossing the subtalar joint or the calcaneus up into the tibia makes this construct even more stable, and it was recommended that we do that. Some of the companies have an option for that through their jig so that you're not going to hit your fixation that you've already locked into the nail. And then a study by Richter in 2014 demonstrated that having 2 posterior to anterior screws made the constructs more robust and stable also. So you see some of these options just have 1 posterior to anterior, and then some have 2. And that said, especially in the osteoporotic bone, to provide more stability and preventing rotation. Overall, you want at least 2 screws proximal and at least 2 screws distal in this construct. And you see this nail, the surgeon only put 1 screw distal and the construct failed. And here you see, this is one of mine, that calcaneal posterior to anterior screw started to back out, and I knew the construct wasn't going to be stable after that occurred. So if you're not familiar with this and this technology, I just want to walk you through the traditional method, how we achieve compression through an intramedullary nail. And there's some advancements in this that we'll cover next. So once the nail is inserted intramedullary, it's locked in place by putting these screws typically up here first in the tibia. And then we've put a screw in this talus there, and you see here there's an engagement of a screwdriver, and we tighten up this internal mechanism, which is in the nail, to allow for compression across the tibiotalar joint, across the ankle joint. So in this slot within the nail, in this example, as the screwdriver is twisted, this nail is driven, pushing the talus into the tibia. And that is the internal compression that we achieve, several millimeters of internal compression that we can achieve with most of these nails. Could you press play on that one? So this is just demonstrating using a screwdriver, and you can see that carriage moves, and you can imagine with a screw in there how that's going to allow the talus to compress into the tibia. Just another picture demonstrating this. Okay, here it is lower in the carriage. You can see this position where we'd start as that screw's inserted, and then the screwdriver is twisted, and this carriage, internal carriage, is driven proximally, allowing for compression as that screw moves upward. This is an Integra design. They've got 2 pins in this example driven through the tibia, and then instead of a screwdriver, they twist this device through their jig and allow for several millimeters of compression across the tibiotalar joint again. And here you see that, you have more of a space across the tibial-talar joint. And then in this example, you can twist on this pretty aggressively, and that space closes down, and you get that good apposition and compression. Newer on the market are titanium nails, but they have a nitinol internal element that allow for recoil or compression through the memory metal. And sounds cool, but in my head I was thinking when I first heard about this, how is nitinol used to provide compression across an ankle joint? So press play on that one for me too. So I'm going to try to make that more clear for you, but it's stretched out, and through the jig is released, and if you watch this carriage, you can see that it slides up. So instead of using the screwdriver to do it, through the memory metal, it wants to tighten and get shorter, and it's stretched out until we release this nut on the bottom of the nail. So if you look at the guts of it, it looks something like this. You got a nitinol pin here, and you lock it in there, and you release the stretch of the memory metal, and then it can allow for compression. Okay, briefly I'll discuss guide wire insertion. Before we insert our nail, we want to get some temporary fixation, and it's important to get it out of the way. You don't want to be reaming into it and hitting into it with your nail. So I try to go out of the way, more anterior with this. We have to start in the calcaneus, and you want to get a good feel for where you're at in the calcaneus so you're not slipping off the medial slope. There is a precision guide that's been developed for this, helping you with your alignment, but I prefer to look at the individual patient anatomy. I mark the patient's tibia preoperatively, and I look at the proximal aspect of their anatomy when I'm driving my nail. So here you see I've marked out the medial aspect of the tibia. Even in these obese patients, you can typically do that. You see I have a bump under their leg here, so I'm not distorted with their calf. But I've marked out the anterior crest of the tibia, which is palpable, the posterior aspect of the tibia, and I've drawn a dotted line as the bisection here. And when I'm driving this nail, for my orientation, I'm looking at it like this. And my orientation, I'm going right to the proximal aspect bisection of those two lines. And then my assistant, my resident or assistant on the side is looking at this, telling me whether I should lower or raise my hand, again, so I'm in axis with this dotted line bisection. Subtalar joint, should we prep it? Should we not prep it? Does it matter? Well, certainly it takes longer if we're going to prep the subtalar joint, right? Studies have shown that at non-unions anyway, about 28% of the time, according to Fenton in 2014, and they said, it was non-painful, so maybe it's a consideration not to really worry about it anyway. A more recent study published earlier this year in JFAS, 2020, in JFAS looked at rheumatoid arthritic patients and showed that 43% of the time it was painful for them. So I'm not sure if that's a across-the-board statement, something we need to look at further. Lowe in 2016 demonstrated that we actually only violate 5.89% of the calcaneus and 4.01% of the talus when it comes to the posterior facet. And we don't really cause that much articular damage. So there's a consideration of even taking out this nail later if we haven't prepped that subtalar joint. And in that case, we wouldn't want compression across the subtalar joint. We'd only want the compression across the tibio-talar joint. This was interesting as I prepared this talk. There's even new development and proof of concept to allow us to have a nail for the ankle joint, which does not violate the subtalar joint. And you can see how this has to be rotated to allow insertion through the lateral talus here. It's not something on the market yet, but stay tuned. Indications for trauma, even in ankle fracture patients, this is something that's become more popularized. Just putting a nail up there, some doctors will fix the fractures, and some in my local area, I see them not even make an attempt to fix the fracture. They just stabilize these fragility fractures in elderly patients using an intramedullary nail. Sometimes it goes well, sometimes I wish they didn't approach it that way. Antibiotic nail considerations, this is the last section. It takes time to remove all this. When we remove it, we can ream the tibia, we can get our cultures, biopsy, chest tube preparation. This picture walks us through this a little bit. The nail's been removed. We've stirred up some vancomycin powder with some antibiotic cement, and then through the caulking gun here, we can prepare that into a chest tube, which is a plastic tube. It's about the size and shape, diameter of the antibiotic nail there, as you can see. And after that sets for about 10-12 minutes, we can score down across this and we can peel off the plastic and insert the intramedullary nail. And I found that this goes much easier by first coating the plastic with this mineral oil, as demonstrated here. So this is available in your OR, and simply coating it with this mineral oil helps this nail peel out much easier than if you didn't do that. Saves a lot of time. Some good considerations when assessing the best option for your patient with intramedullary nail. Some things to think about. Thank you.